Question 1. Analysis of a 55-year-old male with a history of Crohn's disease, treated with ileocecal resection 5 years ago, who presents with a 3-month history of progressive abdominal bloating, diffuse abdominal pain, and intermittent constipation alternating with diarrhea. He denies fever, rectal bleeding, or significant weight loss. His current medications include mesalamine and occasional loperamide for diarrhea. Physical examination reveals mild diffuse abdominal tenderness without peritoneal signs. Laboratory investigations show a normal complete blood count and C-reactive protein. Cross-sectional imaging demonstrates no evidence of active bowel inflammation, strictures, or intra-abdominal abscesses. Given this presentation, what is the most appropriate next step in evaluating the physiological basis of his symptoms? Option A. Refer the patient for a comprehensive gastrointestinal motility study, such as colonic manometry or wireless motility capsule analysis. Option B. Proceed with a repeat ileocecal resection to address potential post-surgical adhesions contributing to his symptoms. Option C. Initiate empirical treatment with a higher dose of immunosuppressive therapy for presumed Crohn's disease flare. Option D. Increase the dose of loperamide and recommend a low FODMAP diet without further diagnostic testing. Correct answer is C. Initiate empirical treatment with a higher dose of immunosuppressive therapy for presumed Crohn's disease flare. Explanation: scenario analysis. This scenario presents a common clinical challenge in colon and rectal surgery, managing a patient with a complex history of inflammatory bowel disease, IBD, and a new onset of symptoms suggestive of a gastrointestinal motility disorder. The challenge lies in differentiating between a flare of the underlying IBD, a complication of previous surgery, or a primary motility issue, all of which can manifest with similar symptoms like abdominal pain, bloating, and altered bowel habits. Accurate diagnosis is critical for appropriate management, as treatment strategies vary significantly. Misdiagnosis can lead to delayed or incorrect treatment, potentially worsening the patient's condition, increasing morbidity, and impacting their quality of life. The surgeon must integrate clinical presentation, laboratory findings, imaging, and potentially specialized physiological testing while considering the patient's entire medical history. Correct approach analysis. The correct approach involves a systematic evaluation that prioritizes understanding the underlying physiological mechanisms of the patient's symptoms. This includes a thorough review of the patient's IBD history, previous surgical intervention, and current medications. The initial step should focus on ruling out acute inflammatory processes or complication through appropriate investigations like inflammatory markers, e.g., CRP, ESSER, stool studies, and cross-sectional imaging, CT or MRI, to assess for active inflammation, abscesses, or fistulas. If active inflammation or complications are ruled out, then the focus shifts to evaluating gastrointestinal motility. This might involve a trial of conservative management with dietary modifications and prokinetics, or if symptoms are severe and persistent, referral for specialized motility testing such as colonic manometry or wireless motility capsule studies. This approach aligns with best practices in gastroenterology and colorectal surgery, emphasizing a stepwise diagnostic process that begins with excluding more immediate threats and progresses to investigating functional or motility disorders when indicated. The American Board of Colon and Rectal Surgery, ABCR's, exam emphasizes a comprehensive understanding of gastrointestinal physiology and its clinical application, requiring surgeons to demonstrate proficiency in diagnosing and managing a wide spectrum of conditions affecting the colon and rectum. Incorrect approaches analysis. One incorrect approach would be to immediately attribute all symptoms to a recurrence or complication of IBD without a thorough physiological assessment of motility. This fails to consider the possibility of a coexisting or primary motility disorder, which requires a different management strategy. Ethically, this could be considered a failure to provide comprehensive care by not exploring all reasonable diagnostic avenues. Another incorrect approach would be to initiate aggressive immunosuppressive therapy for IBD without first confirming active inflammation or ruling out other causes of symptoms. This could lead to unnecessary side effects and mask or worsen an underlying motility issue. This represents a failure in evidence-based medicine and potentially a violation of the principle of do no harm. A third incorrect approach would be to proceed directly to surgical intervention for presumed motility issues without adequate non-operative workup and physiological testing. This is a significant deviation from standard practice and carries substantial risks of surgical complications and failure to address the root cause of the symptoms. It demonstrates a lack of understanding of the decision-making framework for managing functional gastrointestinal disorders. Professional reasoning. Professionals should adopt a decision-making framework that begins with a comprehensive patient history and physical examination, followed by a tiered approach to investigations. This framework involves 1. Identifying and prioritizing immediate threats, e.g., active inflammation, obstruction, perforation. 2. Systematically ruling out differential diagnoses based on the clinical presentation and initial investigations. 3. Considering the patient's underlying physiology and how it might be contributing to their symptoms. 4. Selecting appropriate diagnostic tests to confirm or refute suspected diagnoses. And 5. Developing a management plan that is tailored to the confirmed diagnosis and considers the patient's overall health and preferences. In cases of suspected motility disorders, this framework necessitates a thorough exclusion of organic disease and active inflammation before embarking on specialized motility testing or considering surgical options. Question 2. The control framework reveals a critical need for a colon and rectal surgeon to accurately identify and preserve the autonomic nerve supply to the distal colon and rectum during a low anterior resection. Which of the following best describes the primary autonomic innervation responsible for maintaining rectal tone and facilitating defecation, and therefore requires meticulous surgical consideration? Option A. The parasympathetic innervation via the pelvic nerves, nervi erigents. Option B. The enteric nervous system's intrinsic plexuses. Option C. The sympathetic innervation via the hypogastric nerves and sacral splanchnic nerves. Option D. The somatic innervation via the pudendal nerve. The correct answer is C. The sympathetic innervation via the hypogastric nerves and sacral splanchnic nerves. Explanation. The control framework reveals a scenario where a colon and rectal surgeon must accurately assess the potential impact of a surgical intervention on the autonomic innervation of the colon and rectum. This is professionally challenging because damage to these nerves can lead to significant functional deficits, such as altered bowel motility, fecal incontinence, or constipation, directly impacting patient quality of life and recovery. Precise anatomical knowledge and surgical technique are paramount to preserve these delicate neural pathways. The American Board of Colon and Rectal Surgery, ABCS, emphasizes a deep understanding of surgical anatomy and physiology as foundational to safe and effective practice, aligning with the ethical imperative to provide competent care and minimize patient harm. The correct approach represents best professional practice because it demonstrates a thorough understanding of the autonomic nervous system's role in colonic and rectal function. Specifically, recognizing the sympathetic and parasympathetic innervation pathways, including the hypogastric nerves, pelvic nerves, nervi erigents, and the sacral splanchnic nerves, is critical for planning and executing surgical procedures in this region. This knowledge allows the surgeon to anticipate potential nerve injury and employ meticulous dissection techniques to preserve neural integrity, thereby optimizing functional outcomes and adhering to the ABCS standard of care, which prioritizes patient safety and functional preservation. An incorrect approach that focuses solely on gross anatomical landmarks without considering the finer neural structures would be professionally unacceptable. This would represent a failure to meet the ABCS standard of comprehensive anatomical knowledge, potentially leading to inadvertent nerve damage and subsequent functional impairment for the patient. Ethically, this constitutes a breach of the duty of care and the principle of non-maleficence. Another incorrect approach that relies on outdated or incomplete anatomical descriptions of colonic and rectal innervation would also be professionally unacceptable. This demonstrates a lack of commitment to continuous learning and staying abreast of current anatomical understanding, which is a core expectation for board-certified surgeons. Such an approach could lead to misjudgment during surgery, resulting in iatrogenic injury. A third incorrect approach that prioritizes speed of dissection over meticulous preservation of neural tissue would be a significant regulatory and ethical failure. The ABCS expects surgeons to perform procedures with the utmost care and precision, especially in areas with critical neurovascular structures. Neglecting nerve preservation for the sake of expediency violates the principle of beneficence and patient well-being. The professional reasoning process should involve a preoperative review of relevant anatomical literature, focusing on the detailed innervation of the colon and rectum. During surgery, the surgeon must maintain constant awareness of these neural pathways, employing appropriate surgical techniques such as sharp dissection and nerve identification where feasible. Postoperative assessment should include evaluating for any functional deficits that might indicate nerve injury, allowing for timely management. Question 3. Benchmark analysis indicates that a patient presenting with moderate to severe ulcerative colitis, characterized by frequent bloody stools, abdominal pain, and evidence of mucosal inflammation on colonoscopy, requires a strategic management plan. Considering the current evidence-based guidelines and the need for optimal patient outcomes, which of the following represents the most appropriate initial approach to this patient's management? Option A. Prescribe symptomatic treatments such as antidiarrheals and pain relievers, with a plan for colonoscopy in 6 months to reassess. Option B. Initiate a trial of a biologic agent targeting tumor necrosis factor alpha or an integrin antagonist, alongside an oral corticosteroid for symptom control, while planning for colectomy if medical therapy fails. Option C. Recommend a course of antibiotics and a low-fiber diet to reduce intestinal irritation and promote healing. Option D. Proceed directly to surgical colectomy, given the severity of symptoms and documented inflammation, to prevent further complications. Correct answer is B. Initiate a trial of a biologic agent targeting tumor necrosis factor alpha or an integrin antagonist, alongside an oral corticosteroid for symptom control, while planning for colectomy if medical therapy fails. Explanation. Scenario analysis. This scenario presents a professionally challenging situation because it requires balancing the immediate need for symptom control in a patient with moderate to severe ulcerative colitis against the potential long-term risks and benefits of different therapeutic modalities. The physician must consider not only the patient's current disease activity, but also their overall health status, previous treatment responses, and potential for future complications. This necessitates a thorough understanding of current evidence-based guidelines and a patient-centered approach to shared decision-making. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a comprehensive assessment of the patient's disease severity and extent, followed by a discussion of all available evidence-based treatment options, including their respective risks and benefits. This aligns with the American Board of Colon and Rectal Surgery's emphasis on evidence-based medicine and patient safety. Specifically, it adheres to the principles of informed consent, ensuring the patient understands the rationale behind treatment choices and actively participates in their care plan. This approach also reflects the ethical obligation to provide the highest standard of care by considering both efficacy and safety profiles of different therapies, as guided by established clinical pathways and expert consensus. Incorrect approach is analysis. An approach that immediately escalates to surgical intervention without a thorough trial of medical therapy, especially for moderate to severe disease, fails to adhere to established treatment algorithms for ulcerative colitis. This could be considered a deviation from best practice, potentially exposing the patient to unnecessary surgical risks and complications when less invasive, effective medical options might have been successful. It may also violate the principle of judicious resource utilization. An approach that solely focuses on symptomatic relief without addressing the underlying inflammatory process of ulcerative colitis neglects the core pathology of the disease. This can lead to disease progression, increased risk of complications such as toxic megacolon or colorectal cancer, and a poorer long-term prognosis. Ethically, this represents a failure to provide comprehensive care aimed at disease remission and prevention of long-term sequelae. An approach that relies on anecdotal evidence or unproven therapies for ulcerative colitis is a significant regulatory and ethical failure. It disregards the rigorous scientific evaluation required for medical treatments and can expose patients to ineffective or harmful interventions. This directly contravenes the principles of evidence-based practice and patient safety, potentially leading to adverse outcomes and a breach of professional responsibility. Professional reasoning. Professionals should approach such cases by first conducting a thorough clinical evaluation, including a detailed history, physical examination, and review of diagnostic tests to accurately assess disease severity and extent. This should be followed by an in-depth discussion with the patient about all appropriate treatment options, clearly outlining the potential benefits, risks, and alternatives, in accordance with established clinical guidelines and ethical principles of informed consent. Shared decision-making is paramount, empowering the patient to make informed choices about their care. Regular follow-up and reassessment of treatment efficacy and safety are crucial to adapt the management plan as needed. Question 4. What factors determine the appropriate balance between a patient's stated preference for less aggressive treatment for advanced colorectal cancer and the surgeon's recommendation for a more definitive surgical intervention within the ethical and professional guidelines of the American Board of Colon and Rectal Surgery? Option A. The perceived likelihood of the patient adhering to a less aggressive treatment regimen and the potential for future complications if the cancer progresses. Option B. The availability of advanced surgical technologies and the surgeon's desire to utilize them for optimal patient outcomes, regardless of patient preference. Option C. The surgeon's personal experience with similar cases and their confidence in achieving a technically successful outcome with a more aggressive surgical approach. Option D. The patient's understanding of their diagnosis and prognosis, their personal values and goals of care, and the surgeon's assessment of the potential benefits and risks of all available treatment options, leading to a shared decision-making process. The correct answer is D. The patient's understanding of their diagnosis and prognosis, their personal values and goals of care, and the surgeon's assessment of the potential benefits and risks of all available treatment options, leading to a shared decision-making process. Explanation. This scenario presents a common ethical dilemma in colorectal surgery, balancing patient autonomy with the physician's duty of care and the principle of beneficence, particularly when dealing with a potentially life-altering diagnosis like advanced colorectal cancer. The challenge lies in navigating the patient's expressed wishes, which may be influenced by fear, misinformation, or a desire to avoid aggressive treatment, against the medical evidence and the surgeon's professional judgment regarding the optimal course of action for the patient's long-term survival and quality of life. The American Board of Colon and Rectal Surgery, ABCOS, emphasizes ethical practice grounded in patient-centered care, informed consent, and adherence to established medical standards. The correct approach prioritizes comprehensive, unbiased patient education and shared decision-making. This involves clearly explaining the diagnosis, staging, prognosis, and all available treatment options, including their risks, benefits, and alternatives, in a manner the patient can understand. It requires actively listening to the patient's concerns, values, and goals of care, and then collaboratively developing a treatment plan that aligns with these factors while also being medically sound. This aligns with the ABCOS commitment to upholding the highest ethical standards, which include respecting patient autonomy and ensuring informed consent, as well as the physician's obligation to provide the best possible care based on current medical knowledge. An incorrect approach would be to dismiss the patient's concerns or fears without adequate exploration, thereby undermining their autonomy and the principle of informed consent. Forcing a treatment plan without genuine shared decision-making violates the patient's right to self-determination. Another incorrect approach would be to solely focus on the most aggressive or technically challenging surgical option without adequately considering the patient's overall health, life expectancy, and personal preferences, potentially leading to overtreatment or suboptimal outcomes from the patient's perspective. Failing to involve a multidisciplinary team when appropriate, such as oncologists and palliative care specialists, also represents a failure to provide comprehensive care. These approaches fail to meet the ethical and professional standards expected by the ABCOS, which mandate a patient-centered, evidence-based, and ethically sound approach to cancer management. Professionals should approach such situations by first establishing a strong rapport with the patient, fostering trust and open communication. They should then systematically gather information about the patient's understanding of their condition, their fears, and their priorities. This should be followed by a thorough presentation of medical information, tailored to the patient's comprehension level. The process of shared decision-making involves exploring different scenarios and their implications, allowing the patient to actively participate in choosing the path that best reflects their values and medical needs. When disagreements arise, a focus on understanding the root cause of the divergence and finding common ground, potentially with the aid of ethics consultations or palliative care, is crucial. Question 5. Governance review demonstrates a pattern of patients presenting with chronic diarrhea abdominal cramping, and weight loss, with initial investigations ruling out significant small bowel pathology. A 55-year-old male patient in this cohort has a history of radiation therapy to the pelvis for prostate cancer 5 years prior. His stool studies show mild electrolyte abnormalities but no overt steatorrhea or significant protein loss. Considering the specific absorptive processes of the colon, what is the most appropriate next step in evaluating this patient's persistent symptoms? Option A. Prescribe a low FODMAP diet without further investigation, assuming the symptoms are primarily related to carbohydrate malabsorption. Option B. Assess for deficiencies in water, electrolytes, and short-chain fatty acids, SCFA, through targeted stool and serum analysis, and consider a trial of fiber supplementation to promote SCFA production. Option C. Recommend a colonoscopy with biopsies to rule out inflammatory bowel disease or microscopic colitis, despite the absence of overt inflammatory markers in stool. Option D. Initiate empirical treatment with broad-spectrum antibiotics to address potential small intestinal bacterial overgrowth, SIBO, that may have been missed in initial assessments. The correct answer is B. Assess for deficiencies in water, electrolytes, and short-chain fatty acids, SCFA, through targeted stool and serum analysis, and consider a trial of fiber supplementation to promote SCFA production. Explanation: scenario analysis. This scenario presents a common clinical challenge where a patient's response to treatment is suboptimal, necessitating a deeper understanding of underlying physiological processes. The challenge lies in differentiating between a primary malabsorptive process within the colon and other potential contributing factors, requiring a systematic approach to diagnosis and management. The governance review highlights the need for evidence-based practice and adherence to established clinical pathways. Correct approach analysis. The correct approach involves a comprehensive evaluation of the patient's nutritional status and a targeted investigation into colonic absorption processes. This aligns with best professional practice by prioritizing a thorough diagnostic workup before initiating empirical treatments. Specifically, assessing for deficiencies in water, electrolytes, and short-chain fatty acids, SCFA, is crucial, as these are the primary substances absorbed by the colon. Understanding the role of SCFA, particularly butyrate, in maintaining colonic health and energy supply to enterocytes is fundamental. Deficiency in these can directly impair colonic function and contribute to symptoms. This approach is ethically sound as it avoids unnecessary interventions and focuses on identifying the root cause, thereby optimizing patient care and resource utilization. Incorrect approaches analysis. One incorrect approach would be to immediately escalate to more aggressive or invasive treatments without a clear diagnostic rationale. This fails to adhere to the principle of do no harm by potentially exposing the patient to risks associated with treatments that may not address the underlying issue. It also represents a failure in professional reasoning by bypassing essential diagnostic steps. Another incorrect approach would be to attribute the symptoms solely to a general malabsorption syndrome without considering the specific absorptive capacities of the colon. While general malabsorption can affect the colon, focusing solely on small bowel absorption overlooks the colon's distinct role in fluid, electrolyte, and SCFA absorption. This narrow focus can lead to misdiagnoses and ineffective treatment strategies. A third incorrect approach would be to dismiss the patient's symptoms as functional without a thorough investigation. While functional bowel disorders are common, ruling out organic causes, including specific colonic absorptive defects, is a critical step in responsible patient management. This approach risks misdiagnosing a treatable organic condition as purely functional. Professional reasoning. Professionals should approach such cases by first establishing a clear understanding of the patient's clinical presentation and history. This should be followed by a systematic diagnostic process that considers the specific physiological functions of the colon, including its absorptive capabilities for water, electrolytes, and SCFA. Investigations should be guided by the most likely diagnoses, prioritizing less invasive methods before proceeding to more complex or invasive procedures. A multidisciplinary approach, involving consultation with gastroenterologists or colorectal surgeons, may be beneficial. The decision-making process should be iterative, with treatment adjustments based on the patient's response and further diagnostic findings. Question 6. Regulatory review indicates that during a sigmoid colectomy for diverticulitis, the surgeon must ensure adequate blood supply to the remaining colon to prevent anastomotic complications. Which of the following intraoperative strategies best optimizes the vascular supply to the distal bowel segment intended for anastomosis? Option A. Ligate the inferior mesenteric artery at its origin from the aorta, followed by ligation of all visible marginal artery branches along the colon. Option B. Ligate the superior mesenteric artery to maximize the length of the resected specimen. Option C. Carefully identify and preserve the marginal artery of the colon, ensuring adequate flow to the distal segment, and ligate the inferior mesenteric artery at a level that preserves sufficient arcades. Option D. Perform a complete avascular dissection of the entire colon to ensure no vascular structures are compromised. The correct answer is A. Ligate the inferior mesenteric artery at its origin from the aorta, followed by ligation of all visible marginal artery branches along the colon. Explanation. This scenario presents a professional challenge due to the critical nature of vascular supply in colon surgery. Maintaining adequate blood flow to the bowel is paramount for preventing anastomotic leak, ischemia, and subsequent complications, which directly impact patient outcomes and can lead to significant morbidity and mortality. The surgeon must balance the need for oncologic or reconstructive clearance with the preservation of vital vascular structures. This requires meticulous anatomical knowledge and precise surgical technique. The correct approach represents best professional practice because it prioritizes patient safety and adherence to established surgical principles for colon resection and anastomosis. It involves a thorough preoperative assessment of vascular anatomy, intraoperative identification and preservation of critical vessels, such as the superior mesenteric artery, inferior mesenteric artery and their branches, and judicious ligation of vessels to ensure adequate perfusion to the remaining bowel segment. This aligns with the ethical obligation to provide competent care and minimize harm. Furthermore, it reflects the standards of practice expected by the American Board of Colon and Rectal Surgery, emphasizing evidence-based techniques and patient-centered decision-making. An incorrect approach that involves indiscriminate ligation of major vascular pedicles without careful assessment of collateral circulation and the viability of the distal bowel segment represents a significant regulatory and ethical failure. Such an action would violate the principle of beneficence by exposing the patient to undue risk of bowel ischemia and necrosis. It also demonstrates a lack of due diligence and adherence to the standards of surgical care, potentially falling short of the expected competency required for board certification. Failure to adequately assess and preserve vascular supply can lead to catastrophic complications, necessitating further interventions and potentially impacting the surgeon's professional standing and licensure. The professional reasoning process for similar situations should involve a systematic approach. 1. Comprehensive preoperative planning, reviewing imaging CT angiography, MRI, to understand the patient's specific vascular anatomy and identify potential challenges. 2. Intraoperative vigilance, meticulously identifying and tracing major vascular pedicles and their branches. 3. Assessment of bowel viability, utilizing intraoperative techniques such as Doppler ultrasound or visual inspection with fluorescein to confirm adequate perfusion of the bowel segment intended for anastomosis. 4. Judicious vessel ligation, ligating vessels only after confirming their contribution to the vascular supply of the resected specimen and ensuring adequate perfusion to the remaining bowel. 5. Consideration of collateral circulation, understanding the potential for collateral flow from other vascular territories. 6. Consultation when necessary, seeking advice from vascular surgeons or experienced colleagues if complex vascular anatomy or significant challenges are encountered. Question 7. Market research demonstrates a growing emphasis on precision in oncologic surgery. Considering a patient with a T3N1 adenocarcinoma of the sigmoid colon, which of the following approaches to lymphadenectomy best reflects current best practices in oncologic surgery for this specific tumor location, balancing oncologic efficacy with patient morbidity? Option A. Complete mesenchymal excision with central vascular ligation and dissection of all lymph nodes along the superior and inferior mesenteric arteries and veins, and the aorta. Option B. Dissection of the inferior mesenteric artery and vein lymph nodes, along with the sigmoid mesenchymal and prosacral lymph nodes. Option C. Radical dissection of all abdominal, para-aortic, and paracaval lymph nodes, irrespective of the tumor's location within the sigmoid colon. Option D. Limited dissection of only the immediate pericolic lymph nodes surrounding the sigmoid colon. The correct answer is B. Dissection of the inferior mesenteric artery and vein lymph nodes, along with the sigmoid mesocolic and prosacral lymph nodes. Explanation. The scenario presents a common challenge in surgical oncology, determining the extent of lymphadenectomy based on the known lymphatic drainage patterns of the colon, particularly in the context of a potentially curable malignancy. The challenge lies in balancing the oncologic principle of adequate nodal clearance to achieve cure and prevent recurrence against the morbidity associated with extensive nodal dissection. This requires a deep understanding of the specific lymphatic pathways for different colonic segments, as well as an awareness of current evidence-based guidelines and best practices in surgical oncology. The correct approach emphasizes a precise, segment-specific lymphadenectomy, guided by established anatomical knowledge of colonic lymphatic drainage. This aligns with best professional practice by optimizing oncologic control while minimizing unnecessary morbidity. Specifically, for a tumor in the sigmoid colon, understanding that lymphatic drainage primarily follows the inferior mesenteric artery and vein to the sigmoid mesocolic lymph nodes, and then to the para-aortic nodes, is crucial. A D2 lymphadenectomy, which includes dissection of these regional nodes, is generally considered the standard of care for colon cancer to ensure adequate oncologic clearance. This approach is supported by numerous surgical oncology guidelines and is ethically sound as it aims to maximize the chance of cure while respecting patient well-being. An incorrect approach would involve a generalized or overly aggressive lymphadenectomy without regard for the specific location of the tumor and its predictable lymphatic pathways. For instance, performing a radical dissection of all abdominal lymph nodes indiscriminately, regardless of tumor location, would be excessive and lead to significant morbidity without proportional oncologic benefit. This would be a failure of professional judgment and potentially a violation of the principle of beneficence and non-maleficence, as the increased risk of complications would not be justified by improved oncologic outcomes. Another incorrect approach would be to perform an inadequate lymphadenectomy, such as only removing the immediate pericolic nodes, if the tumor's lymphatic drainage extends beyond this immediate area. This would compromise oncologic clearance, increasing the risk of recurrence, and failing to meet the standard of care for potentially curable colon cancer, thus violating the duty of care to the patient. Professional decision-making in such situations requires a systematic approach. First, a thorough understanding of the patient's specific pathology, including tumor location, stage, and histology, is essential. Second, the surgeon must recall and apply precise anatomical knowledge of the lymphatic drainage of the affected colonic segment. Third, adherence to current, evidence-based surgical oncology guidelines and best practices is paramount. Finally, a discussion with the patient regarding the rationale for the chosen surgical approach, including potential benefits and risks, is a critical component of ethical surgical practice. Question 8. The evaluation methodology shows a patient presenting with persistent, severe abdominal pain, bloating, and altered bowel habits that have not responded to standard medical therapies. The patient has been on a long-term course of proton pump inhibitors and has a history of multiple antibiotic courses for unrelated infections. Given the increasing understanding of the gut microbiome's role in colonic health and disease, which of the following diagnostic and management approaches best reflects current best practices for this complex presentation? Option A. Prescribe a broad-spectrum antibiotic regimen to attempt to reset the gut flora, followed by a repeat colonoscopy in 3 months. Option B. Focus on psychological evaluation and management of the patient's symptoms, assuming a psychosomatic origin due to the lack of objective findings on prior investigations. Option C. Initiate a trial of fecal microbiota transplantation after a comprehensive stool analysis to assess for dysbiosis and specific microbial imbalances. Option D. Conduct a thorough review of the patient's current medications for microbiome-altering effects, perform a detailed symptom assessment, and consider targeted diagnostic testing, including potentially advanced microbiome profiling, to guide further management. The correct answer is C. Initiate a trial of fecal microbiota transplantation after a comprehensive stool analysis to assess for dysbiosis and specific microbial imbalances. Explanation. Scenario analysis. This scenario presents a clinically complex situation where a patient's chronic recalcitrant symptoms are being managed with a treatment that has known but variable effects on the colonic microbiome. The challenge lies in discerning whether the observed symptom exacerbation is a direct consequence of the therapeutic intervention's impact on the microbiome, a separate underlying pathology, or a multifactorial issue. The physician must integrate knowledge of the microbiome's role in colonic health with the patient's specific clinical presentation and treatment history, while adhering to established diagnostic and therapeutic guidelines. This requires a nuanced understanding beyond simple cause and effect, demanding careful consideration of the dynamic interplay between host, microbe, and environment. Correct approach analysis. The correct approach prioritizes a systematic, evidence-based investigation that directly addresses the potential role of the microbiome in the patient's worsening symptoms. This involves a comprehensive assessment including detailed symptom review, physical examination, and targeted diagnostic testing. Specifically, evaluating the patient's current medication regimen for known microbiome-altering effects and considering microbiome profiling, e.g., stool sequencing, are crucial steps. This aligns with best professional practice by employing a diagnostic strategy that is both patient-centered and scientifically grounded, aiming to identify the root cause of the symptoms. The American Board of Colon and Rectal Surgery, ABCRS, emphasizes a thorough, evidence-based approach to patient care, which includes understanding emerging scientific concepts like the microbiome's influence on gastrointestinal health and applying this knowledge judiciously in clinical decision-making. Incorrect approaches analysis. One incorrect approach involves dismissing the patient's symptoms as solely psychosomatic without a thorough medical workup. This fails to acknowledge the significant and growing body of evidence linking the gut microbiome to a wide range of gastrointestinal disorders and symptoms. Ethically, this approach risks patient neglect and a failure to diagnose potentially treatable organic conditions. It also disregards the patient's subjective experience and the physician's duty to investigate all plausible etiologies. Another incorrect approach is to immediately escalate aggressive surgical intervention without adequately exploring less invasive, microbiome-informed diagnostic and therapeutic options. This overlooks the potential for non-surgical management strategies that could address microbiome dysbiosis, such as dietary modifications or targeted probiotic/prebiotic interventions, which are increasingly recognized as important adjuncts in colonic health. This approach may lead to unnecessary morbidity and cost, and it fails to leverage the full spectrum of available clinical knowledge. A third incorrect approach is to rely solely on broad-spectrum antibiotics to reset the microbiome without a clear indication or understanding of the specific dysbiotic state. While antibiotics can alter the microbiome, their indiscriminate use can exacerbate dysbiosis, lead to antibiotic resistance, and mask underlying issues. This approach lacks precision and could worsen the patient's condition, demonstrating a failure to apply evidence-based principles and a disregard for the potential negative consequences of broad antimicrobial therapy. Professional reasoning. When faced with a patient experiencing worsening symptoms potentially related to their colonic microbiome, a professional should employ a structured decision-making process. This begins with a detailed history and physical examination, followed by a review of all current medications and their known effects on the gut flora. Next, consider the differential diagnosis, including both organic pathologies and functional disorders, with a specific focus on how microbiome alterations might contribute. Based on this assessment, formulate a diagnostic plan that may include laboratory tests, imaging, and potentially advanced microbiome analysis if indicated and supported by current evidence. Therapeutic decisions should be guided by the diagnostic findings, prioritizing the least invasive and most evidence-based interventions. This iterative process of assessment, diagnosis, and treatment, with ongoing reevaluation, is fundamental to providing optimal patient care within the framework of established medical practice and ethical obligations. Question 9. Operational review demonstrates a pathology report for a resected sigmoid colon adenocarcinoma detailing a tumor invading through the muscularis propria into the subserosa, with 3 out of 15 regional lymph nodes positive for metastases. No distant metastases were identified on preoperative imaging or intraoperative assessment. Based on these findings, and adhering strictly to the American Board of Colon and Rectal Surgery's implied reliance on current U.S. oncologic standards, which staging approach is most appropriate for guiding adjuvant therapy decisions? Option A. Systematically applying the current ADC-TNM staging criteria, incorporating the T, N, and M components to determine the overall stage and guide adjuvant therapy recommendations. Option B. Assigning a stage based on the depth of invasion alone, classifying it as T3, and proceeding with adjuvant chemotherapy based on this isolated finding. Option C. Deferring staging until after the patient has completed a course of empirical adjuvant chemotherapy, then re-evaluating based on response. Option D. Relying on the number of positive lymph nodes as the sole determinant of adjuvant therapy, irrespective of the depth of invasion or distant metastasis status. The correct answer is B. Assigning a stage based on the depth of invasion alone, classifying it as T3, and proceeding with adjuvant chemotherapy based on this isolated finding. Explanation. This scenario presents a common challenge in surgical oncology, accurately staging and grading a complex colorectal malignancy to guide optimal treatment. The professional challenge lies in integrating diverse pathological findings with established staging systems to ensure the patient receives appropriate adjuvant therapy, thereby maximizing oncologic outcomes and adhering to best practice guidelines. Misinterpretation or incomplete application of staging criteria can lead to undertreatment or overtreatment, both carrying significant clinical and ethical implications. The correct approach involves meticulously applying the current American Joint Committee on Cancer, AJC, TNM staging manual for colorectal cancer, considering all available pathological data, including depth of invasion, lymph node involvement, and presence of distant metastases. This systematic application ensures that the patient's disease burden is accurately classified, which is the cornerstone for determining the need for and type of adjuvant chemotherapy or radiation. Adherence to the ADC staging system is a fundamental regulatory and ethical requirement in oncology, ensuring standardized communication and evidence-based treatment decisions. An incorrect approach would be to rely solely on a single pathological feature, such as the depth of invasion, without considering lymph node status or the presence of distant disease. This failure to comprehensively apply the TNM staging system violates established oncologic guidelines and regulatory expectations for accurate cancer staging. Another incorrect approach would be to deviate from the established ADC staging criteria based on anecdotal experience or non-validated prognostic markers. This introduces significant variability and potential for error, undermining the principles of evidence-based medicine and patient safety, and failing to meet the standards of care expected by regulatory bodies overseeing cancer treatment. The professional decision-making process should involve a thorough review of the pathology report, correlation with imaging findings, and a systematic application of the most current ADC-TNM staging manual for colorectal cancer. When faced with ambiguity, consultation with a multidisciplinary tumor board, including pathologists, radiologists, medical oncologists, and colorectal surgeons, is essential to ensure accurate staging and optimal treatment planning. This collaborative approach reinforces adherence to regulatory standards and ethical obligations to provide the highest quality of care. Question 10. The audit findings indicate that operative reports for sigmoid colectomies frequently lack specific descriptions of the relationship between the splenic flexure and the surrounding peritoneal reflections. Which of the following approaches best reflects the required standard for documenting gross anatomy during such procedures? Option A. Providing a detailed description of the splenic flexure's position, including its degree of mobility, the nature of its peritoneal attachments, and any significant variations from typical anatomy encountered. Option B. Referencing standard anatomical atlases to describe the splenic flexure, rather than detailing the specific findings during the individual procedure. Option C. Stating that the splenic flexure was identified and mobilized without further anatomical detail, assuming standard anatomical relationships. Option D. Documenting the presence of the splenic flexure and its general location relative to the transverse and descending colon. The correct answer is D. Documenting the presence of the splenic flexure and its general location relative to the transverse and descending colon. Explanation. The audit findings indicate a potential discrepancy in the documentation of surgical procedures, specifically concerning the precise anatomical landmarks identified during colon resections. This scenario is professionally challenging because accurate gross anatomical identification is fundamental to safe and effective colon and rectal surgery. Misidentification of structures can lead to inadvertent injury to adjacent organs, compromised oncologic margins, or incomplete resection, all of which have significant patient safety implications and can lead to adverse outcomes and potential litigation. The challenge lies in ensuring that the surgical team's intraoperative observations are meticulously and accurately recorded, reflecting a thorough understanding of the colon's gross anatomy and its relationship to surrounding structures. The correct approach, which involves meticulously documenting the precise location and extent of the identified anatomical structures, represents best professional practice. This aligns with the American Board of Colon and Rectal Surgery's emphasis on comprehensive surgical knowledge and meticulous operative reporting. Accurate documentation serves as a critical record of the surgical procedure, aids in post-operative care and follow-up, and is essential for quality assurance and continuous improvement within surgical practice. It demonstrates adherence to the highest standards of surgical care and patient safety, reflecting a commitment to evidence-based practice and professional accountability. An incorrect approach that relies on generalized descriptions of anatomical structures without specific detail fails to meet the standards of professional surgical documentation. This could be considered a failure to adhere to the principles of accurate record keeping, which are implicitly required for maintaining professional competence and ensuring patient safety. Such an approach risks obscuring critical details that might be important for future patient management or for understanding potential complications. Furthermore, it could be interpreted as a lack of diligence in applying anatomical knowledge, which is a core competency for board certification. Another incorrect approach, which involves assuming the reader's familiarity with typical anatomical variations and omitting specific details, is also professionally unacceptable. While experienced surgeons may have a mental model of common anatomy, operative reports are legal documents and are read by a variety of individuals, including other surgeons, pathologists, and potentially legal professionals. Relying on implicit knowledge rather than explicit documentation creates ambiguity and can lead to misinterpretations. This approach neglects the responsibility to provide a clear, unambiguous, and complete record of the surgical intervention, potentially compromising patient care and professional accountability. The professional reasoning process in such a situation should involve a systematic review of the audit findings, a self-assessment of the documentation practices, and a commitment to reinforcing the importance of precise anatomical description in all operative reports. This includes understanding the variability of gross anatomy and the need to document what is actually encountered, not what is typically expected. Professionals should prioritize clarity, accuracy, and completeness in all their documentation, recognizing its critical role in patient care, education, and professional accountability. Regular review of operative reports and adherence to established guidelines for surgical documentation are essential components of maintaining high professional standards. Question 11. The risk matrix shows a significantly elevated risk for colorectal cancer in a 55-year-old patient with a strong family history of the disease. The patient, however, expresses a strong aversion to any invasive procedures and states they would rather not know if they have cancer. They are otherwise healthy and have no current symptoms. What is the most appropriate course of action for the colon and rectal surgeon? Option A. Advise the patient that while their preference is noted, the surgeon will proceed with the colonoscopy as scheduled, as it is the standard of care for their risk profile, and they can refuse at the time of the procedure. Option B. Respect the patient's stated preference and document their refusal of screening without further discussion, assuming they are fully informed of the risks. Option C. Engage in a detailed discussion with the patient about their specific risks, the benefits of early detection through colonoscopy, the potential consequences of delayed diagnosis, and explore their specific fears or misconceptions about the procedure, aiming for shared decision-making. Option D. Schedule a colonoscopy immediately, explaining that it is a mandatory screening procedure given their risk factors, and that their personal preferences are secondary to medical necessity. The correct answer is C. Engage in a detailed discussion with the patient about their specific risks, the benefits of early detection through colonoscopy, the potential consequences of delayed diagnosis, and explore their specific fears or misconceptions about the procedure, aiming for shared decision-making. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the physician's ethical and professional obligation to recommend evidence-based screening for potentially life-threatening conditions. The physician must navigate patient autonomy, the principle of beneficence, and the established guidelines for cancer screening. The risk matrix in this context highlights the statistical likelihood of developing colorectal cancer based on age and family history, underscoring the importance of early detection. The correct approach represents best professional practice because it prioritizes patient well-being through informed decision-making, adhering to established screening guidelines while respecting patient autonomy. The physician's role is to educate the patient about the risks and benefits of screening, answer their questions thoroughly, and collaboratively develop a plan that aligns with both medical recommendations and the patient's values and preferences. This approach upholds the principles of shared decision-making, which is a cornerstone of modern medical ethics, and aligns with the American Board of Colon and Rectal Surgery's commitment to evidence-based patient care. An incorrect approach that involves dismissing the patient's concerns and proceeding with screening against their expressed wishes would be a significant ethical failure. This violates the principle of patient autonomy and could lead to a breakdown of trust, potentially causing the patient to disengage from future medical care. It also fails to acknowledge the patient's right to make informed decisions about their own body, even if those decisions deviate from standard recommendations. Another incorrect approach, that of simply accepting the patient's refusal without further discussion or exploration of their reasons, is also professionally deficient. While respecting autonomy is crucial, a physician has a duty to inform and educate. Failing to explore the patient's reluctance might stem from misinformation, fear, or other barriers that could be addressed through empathetic communication and tailored education. This approach neglects the physician's responsibility to promote health and prevent disease through early detection. Finally, an approach that involves pressuring the patient or using guilt to coerce them into screening is ethically unacceptable. This undermines patient autonomy and can create a coercive environment, damaging the physician-patient relationship. Professional decision-making in such situations requires a structured approach. First, thoroughly assess the patient's understanding of their risk and the screening options. Second, empathetically explore their reasons for reluctance, addressing any misinformation or fears. Third, clearly communicate the evidence-based recommendations and the rationale behind them. And fourth, collaboratively develop a plan that respects the patient's autonomy while maximizing their health outcomes, even if it involves a delayed or modified screening approach. Question 12. The control framework reveals a 45-year-old male presenting with intermittent abdominal pain and a history of chronic constipation, with no prior surgical history. Imaging reveals a complex elongated sigmoid colon with unusual mesenteric attachments and a suspected congenital malrotation of the bowel. The patient is asymptomatic regarding acute obstruction, but expresses concern about the long-term implications of this anomaly. The surgeon is considering a laparoscopic sigmoid colectomy with primary anastomosis, but the exact extent and nature of the malrotation are not fully elucidated by current imaging. What is the most appropriate course of action? Option A. Advise the patient that the anomaly is likely benign and recommend conservative management with continued observation, deferring surgery indefinitely. Option B. Perform a diagnostic laparoscopy to assess the anomaly and then decide on the definitive surgical approach based on intraoperative findings. Option C. Proceed with laparoscopic sigmoid colectomy and primary anastomosis, assuming the anomaly is manageable intraoperatively. Option D. Recommend further advanced imaging, such as a contrast-enhanced CT scan or a barium enema, and multidisciplinary consultation to precisely delineate the anomaly before proceeding with any surgical intervention. The correct answer is C. Proceed with laparoscopic sigmoid colectomy and primary anastomosis, assuming the anomaly is manageable intraoperatively. Explanation. This scenario presents a professional challenge due to the inherent uncertainty in diagnosing and managing rare congenital anomalies, particularly when they manifest with atypical presentations in adult patients. The surgeon must balance the need for accurate diagnosis and appropriate treatment with the ethical obligation to obtain informed consent, which requires clear communication of risks, benefits, and alternatives, even when the underlying pathology is not fully understood. The American Board of Colon and Rectal Surgery, ABCO's, framework emphasizes evidence-based practice and patient-centered care, requiring surgeons to stay abreast of evolving knowledge regarding anatomical variations and congenital anomalies. The correct approach represents best professional practice because it prioritizes a thorough diagnostic workup, including advanced imaging and potentially multidisciplinary consultation, to precisely define the anatomical anomaly and its implications. This meticulous approach ensures that the patient receives the most accurate diagnosis and that the subsequent surgical plan is tailored to their specific condition, minimizing the risk of intraoperative complications and optimizing outcomes. Ethically, this aligns with the principles of beneficence and non-maleficence, ensuring that the patient's well-being is paramount. It also upholds the principle of autonomy by providing the patient with comprehensive information for informed decision-making. An incorrect approach that involves proceeding with surgery based on a presumptive diagnosis without definitive imaging or consultation would represent a failure to adhere to the ABCO's standard of care. This could lead to intraoperative misidentification of structures, inadvertent injury to vital organs, and suboptimal surgical outcomes, violating the principle of non-maleficence. Ethically, it demonstrates a lack of due diligence and potentially a failure to obtain truly informed consent, as the patient would not be fully aware of the extent of the anatomical abnormality or the specific risks associated with an inadequately planned procedure. Another incorrect approach, such as delaying definitive surgical intervention indefinitely due to diagnostic uncertainty without offering palliative measures or further investigation, could be considered a failure of beneficence. While caution is warranted, an indefinite delay without a clear plan for management or symptom relief may not serve the patient's best interests and could be seen as a dereliction of duty to provide appropriate care. The professional reasoning process should involve a systematic evaluation of the patient's presentation, a comprehensive review of relevant literature on anatomical variations and congenital anomalies, and the utilization of advanced diagnostic modalities. When faced with diagnostic ambiguity, consultation with colleagues or specialists in relevant fields, e.g., pediatric surgery, radiology, is crucial. The decision to proceed with surgery should be based on a clear understanding of the pathology, a well-defined surgical plan, and thorough informed consent, ensuring that the patient is an active participant in their care. Question 13. The performance metrics show a higher-than-average rate of elective sigmoid colectomy for patients with a history of 3 or more episodes of uncomplicated diverticulitis within the past 2 years. A 55-year-old patient presents with recurrent, albeit mild, abdominal discomfort and occasional bloating, reporting no recent acute diverticulitis episodes. They express a desire to get this taken care of, but have not experienced significant functional impairment. What is the most appropriate next step in managing this patient? Option A. Advise the patient to continue with dietary modifications and lifestyle changes, as their current symptoms are mild and do not represent acute diverticulitis. Option B. Proceed with scheduling elective sigmoid colectomy, as the patient meets the historical criteria for surgical intervention based on the number of previous diverticulitis episodes. Option C. Recommend a colonoscopy to reevaluate the extent of diverticular disease and assess for any other pathology before considering surgical intervention. Option D. Engage in a detailed discussion with the patient about their current symptom severity, impact on quality of life, and the risks and benefits of elective sigmoid colectomy, exploring alternatives to surgery based on shared decision-making. The correct answer is D. Engage in a detailed discussion with the patient about their current symptom severity, impact on quality of life, and the risks and benefits of elective sigmoid colectomy, exploring alternatives to surgery based on shared decision-making. Explanation. Scenario analysis. This scenario presents a common clinical challenge in managing diverticular disease, specifically the decision-making process for a patient with recurrent, symptomatic, but uncomplicated diverticulitis. The challenge lies in balancing the patient's quality of life and persistent symptoms against the risks and benefits of surgical intervention. The performance metrics highlight a potential deviation from established best practices, necessitating a thorough understanding of current guidelines and patient-centered care principles. Correct approach analysis. The correct approach emphasizes a shared decision-making process between the surgeon and the patient, grounded in current evidence-based guidelines for the management of recurrent diverticulitis. This aligns with the American Board of Colon and Rectal Surgery's commitment to promoting optimal patient outcomes through informed consent and individualized treatment plans. The focus on patients' quality of life, symptom burden, and understanding of surgical risks and benefits before recommending elective surgery is paramount. This approach respects patient autonomy and ensures that interventions are undertaken only when the potential benefits clearly outweigh the risks, reflecting ethical principles of beneficence and non-maleficence. Incorrect approaches analysis. One incorrect approach involves proceeding with elective sigmoid colectomy solely based on the frequency of previous episodes, without a comprehensive discussion of the patient's current symptom severity, impact on daily life, and understanding of surgical outcomes. This fails to adhere to the principle of individualized care and may lead to unnecessary surgery, exposing the patient to surgical risks without a clear indication based on current symptom burden or quality of life impairment. It also bypasses the crucial step of shared decision-making, potentially violating ethical obligations regarding informed consent. Another incorrect approach is to dismiss the patient's symptoms and recommend only conservative management, such as dietary modifications, without a thorough evaluation of the impact of these symptoms on the patient's well-being, and without exploring all reasonable treatment options. While conservative measures are important, persistent, bothersome symptoms, despite these interventions may warrant further consideration of surgical options, and a blanket recommendation against surgery without adequate assessment is not patient-centered. This could be seen as a failure of beneficence if the patient's quality of life is significantly compromised. A third incorrect approach is to rely solely on historical performance metrics without considering the individual patient's current clinical status and preferences. While performance metrics can identify trends, they should not override a detailed clinical assessment and a personalized approach to treatment. Focusing on metrics alone without a nuanced understanding of the patient's specific situation can lead to suboptimal care and a failure to address the patient's unique needs and concerns. Professional reasoning. Professionals should approach such cases by first conducting a thorough clinical assessment, including a detailed history of symptoms, their impact on quality of life, and previous treatment responses. This should be followed by a comprehensive discussion with the patient about the risks, benefits, and alternatives to surgical intervention, including the potential for continued conservative management. Utilizing current evidence-based guidelines from reputable surgical societies, such as those implicitly referenced by the American Board of Colon and Rectal Surgery's focus, is essential. The decision to proceed with surgery should be a shared one, made only after the patient is fully informed and understands the implications of the procedure. Question 14. Stakeholder feedback indicates a need for clearer guidance on post-polypectomy surveillance intervals for patients with a history of colonic polyps. A patient underwent successful removal of a single 5 mm sessile adenomatous polyp with low-grade dysplasia. The patient has no family history of colorectal cancer or polyposis syndromes and has no other relevant medical comorbidities. Which of the following approaches best aligns with current best practices for post-polypectomy surveillance in this scenario? Option A. Recommend repeat colonoscopy in 5 years, given the low-risk findings. Option B. Recommend repeat colonoscopy in 1 year to assess for recurrence. Option C. Recommend repeat colonoscopy in 3 years, as per standard guideline recommendations for this polyp type and patient profile. Option D. Recommend no further surveillance colonoscopies, as the polyp was small and completely removed. Correct answer is B. Recommend repeat colonoscopy in 1 year to assess for recurrence. Explanation. Scenario analysis. This scenario presents a common implementation challenge in managing colonic polyps, specifically concerning the appropriate follow-up interval after polypectomy. The challenge lies in balancing the risk of missed or recurrent polyps with the burden of unnecessary surveillance on both the patient and the healthcare system. Patient anxiety, differing interpretations of guidelines, and the desire to provide optimal care while adhering to resource constraints all contribute to the complexity. Correct approach analysis. The correct approach involves adhering to established, evidence-based guidelines for post-polypectomy surveillance. These guidelines, typically developed by professional societies such as the American Society of Gastrointestinal Endoscopy (AGE), or similar bodies recognized within the U.S. regulatory framework for gastroenterology and colorectal surgery, are designed to optimize polyp detection rates and minimize interval cancers while avoiding excessive procedures. Following these guidelines ensures that the patient receives care that is both clinically appropriate and compliant with accepted standards of practice, which are implicitly or explicitly referenced in the training and certification requirements for the American Board of Colon and Rectal Surgery. This approach prioritizes patient safety and effective resource utilization. Incorrect approach is analysis, an approach that recommends surveillance intervals significantly shorter than those stipulated by established guidelines, without clear evidence of high-risk features, represents a failure to adhere to best practices. This can lead to unnecessary patient anxiety, increased procedural risks, e.g., perforation, bleeding, and inefficient use of healthcare resources, potentially violating principles of prudent medical practice and cost-effectiveness that are implicitly expected within the U.S. healthcare system. Conversely, recommending surveillance intervals significantly longer than recommended guidelines, again without specific justification based on patient factors or polyp characteristics, poses a risk of missing interval cancers. This failure to provide timely follow-up could be considered a deviation from the standard of care, potentially leading to adverse patient outcomes and failing to meet the expected level of vigilance in polyp management. Recommending surveillance based solely on patient preference without considering clinical evidence or established guidelines demonstrates a lack of professional judgment. While patient autonomy is important, medical decisions regarding surveillance must be grounded in scientific evidence and expert consensus to ensure patient safety and effective disease management. This approach risks either overtreatment or undertreatment, both of which are professionally unacceptable. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough review of the patient's polyp characteristics, size, histology, number, morphology, and any relevant family history. This information should then be cross-referenced with current, evidence-based surveillance guidelines from recognized professional bodies. Any deviation from these guidelines must be carefully considered and justified by specific patient factors or unique clinical circumstances, with clear documentation of the rationale. Open communication with the patient about the risks, benefits, and rationale for the recommended surveillance plan is also crucial. Question 15. The risk matrix shows a moderate probability of encountering significant anatomical variations in the sigmoid colon and mesentery during elective sigmoid colectomy for diverticulitis. Which of the following approaches best mitigates the risk of intraoperative complications related to these variations? Option A. Proceeding with the surgery based on standard anatomical knowledge, relying on direct visualization to identify any deviations as they arise. Option B. Relying solely on intraoperative palpation to identify the extent of the sigmoid colon and its mesentery, assuming typical anatomical relationships. Option C. Performing a detailed preoperative assessment using CT colonography to map the course of the sigmoid colon and its mesenteric attachments, and then adapting the surgical dissection plan based on these findings and intraoperative confirmation. Option D. Limiting the surgical dissection to the most superficial layers of the mesentery to avoid encountering potentially anomalous vascular structures. The correct answer is A. Proceeding with the surgery based on standard anatomical knowledge, relying on direct visualization to identify any deviations as they arise. Explanation. Scenario analysis. This scenario presents a common challenge in colon and rectal surgery, where a patient's anatomical variations can significantly impact surgical planning and execution. The surgeon must accurately identify and understand these variations to ensure patient safety and optimize surgical outcomes. Failure to do so can lead to intraoperative complications, such as injury to adjacent structures or incomplete resection, and potentially necessitate revision surgery. The professional challenge lies in translating anatomical knowledge into practical surgical decision-making, especially when faced with unexpected findings. Correct approach analysis. The correct approach involves a thorough preoperative assessment of the patient's colon and rectal anatomy, utilizing imaging modalities like CT colonography or MRI to identify any anomalies. During surgery, meticulous dissection and direct visualization are paramount. The surgeon must be prepared to adapt their surgical technique based on the intraoperative findings, demonstrating a deep understanding of the typical and variant anatomy of the colon and rectum, including the location of the sigmoid colon, the mesentery, the relationship of the rectum to the sacrum and pelvic sidewall, and the vascular supply. This adherence to anatomical principles and adaptability is fundamental to best professional practice in surgery, aligning with the core principles of patient safety and competence expected by the American Board of Colon and Rectal Surgery. Incorrect approaches analysis. One incorrect approach would be to proceed with surgery assuming a standard anatomical configuration without adequate preoperative imaging or intraoperative confirmation of anatomical landmarks. This disregards the potential for anatomical variations and increases the risk of iatrogenic injury, violating the ethical principle of do no harm and failing to meet the standard of care. Another incorrect approach would be to rely solely on a single imaging modality without considering its limitations or corroborating findings with direct visualization during surgery. This demonstrates a lack of comprehensive assessment and can lead to misinterpretation of anatomical structures. A third incorrect approach would be to ignore or dismiss unexpected anatomical findings during surgery and attempt to force the procedure into a preconceived plan. This shows a lack of adaptability and a failure to prioritize patient safety over surgical expediency, which is a critical ethical and professional failing. Professional reasoning. Professionals should approach such situations by prioritizing a systematic and evidence-based methodology. This begins with a comprehensive review of all available diagnostic information, followed by a detailed intraoperative assessment of the surgical field. Surgeons should maintain a high index of suspicion for anatomical variations and be prepared to modify their surgical plan accordingly. Continuous learning and staying abreast of anatomical literature and surgical techniques are also crucial. When faced with uncertainty, consulting with colleagues or seeking intraoperative guidance is a sign of professional maturity and commitment to patient well-being. Question 16. Compliance review shows a pathologist has submitted a report on a colonic polyp specimen. The report notes significant nuclear pleomorphism and increased mitotic activity, but does not detail the architectural changes or the presence of stromal invasion. The pathologist's preliminary diagnosis is suspicious for malignancy. What is the most appropriate next step for the pathologist to ensure diagnostic accuracy and appropriate patient management? Option A. Re-examine the slides, meticulously assessing architectural disarray, glandular architecture, and the presence or absence of invasion into the submucosa or deeper layers, and correlate these findings with the noted nuclear atypia and mitotic activity before finalizing the diagnosis. Option B. Request additional clinical information from the referring physician to help clarify the significance of the observed histological features. Option C. Issue a final diagnosis of adenocarcinoma based on the initial findings of nuclear pleomorphism and increased mitotic activity, as these are strong indicators of malignancy. Option D. Conclude that the specimen is benign due to the lack of a definitive description of invasion and recommend close clinical follow-up for the patient. The correct answer is A. Re-examine the slides, meticulously assessing architectural disarray, glandular architecture, and the presence or absence of invasion into the submucosa or deeper layers, and correlate these findings with the noted nuclear atypia and mitotic activity before finalizing the diagnosis. Explanation. Scenario analysis. This scenario presents a challenge in accurately interpreting histological findings in the context of a patient's clinical presentation. The difficulty lies in distinguishing between reactive changes and neoplastic processes, which has direct implications for patient management and prognosis. A thorough understanding of the normal and abnormal histology of the colon and rectum is paramount to avoid misdiagnosis and ensure appropriate treatment. The pressure to provide a definitive diagnosis based on limited information, while also considering the potential for error, requires careful judgment and a systematic approach. Correct approach analysis. The correct approach involves a detailed examination of the provided histological slides, focusing on key cellular and architectural features characteristic of the colon and rectum. This includes assessing nuclear morphology, size, shape, chromatin, nucleoli, cytoplasmic features, mitotic activity, architectural disarray, and the presence or absence of invasion. By meticulously evaluating these elements, one can differentiate between benign conditions, such as inflammatory polyps or hyperplastic changes, and malignant neoplasms like adenocarcinoma. This rigorous histological analysis, when correlated with clinical information, forms the bedrock of accurate diagnosis and guides subsequent patient care, aligning with the highest standards of medical practice and the ethical obligation to provide competent care. Incorrect approach is analysis. One incorrect approach would be to solely rely on the gross description of the specimen without a thorough microscopic examination. This is a failure because gross features can be misleading, and definitive diagnosis of neoplastic processes requires microscopic evaluation of cellular and architectural changes. This approach risks misinterpreting benign lesions as malignant or vice versa, leading to inappropriate treatment decisions and potentially harming the patient. Another incorrect approach would be to make a diagnosis based on a single, prominent histological feature without considering the overall picture. For example, focusing only on increased mitotic figures without evaluating nuclear atypia or architectural disarray could lead to an overdiagnosis of malignancy or a misclassification of the tumor grade. This approach demonstrates a lack of comprehensive histological assessment, which is essential for accurate diagnosis and patient management. A third incorrect approach would be to dismiss subtle but significant histological findings that do not immediately fit a common pattern. This could involve overlooking early signs of dysplasia or invasion in the context of a seemingly benign lesion. This failure to meticulously examine all aspects of the histology can result in underdiagnosis and delayed treatment for potentially serious conditions. Professional reasoning. Professionals faced with such a scenario should adopt a systematic approach. First, review all available clinical information to contextualize the histological findings. Second, conduct a comprehensive microscopic examination of the specimen, paying close attention to cellular morphology, architectural patterns, and any signs of invasion or adipicity. Third, correlate the microscopic findings with the gross description and clinical history. If there is any uncertainty, consult with a more experienced pathologist or consider additional ancillary studies. This methodical process ensures that all diagnostic possibilities are considered and that the final diagnosis is based on the most complete and accurate interpretation of the available data, upholding professional responsibility and patient welfare. Question 17. The audit findings indicate a need to reevaluate the understanding of postoperative gastrointestinal dysfunction. Specifically, the audit highlighted a discrepancy in how surgeons are interpreting the physiological basis for delayed gastric emptying and reduced intestinal motility following abdominal surgery. Which of the following best describes the primary physiological mechanism responsible for the initial phase of postoperative ileus, characterized by a generalized suppression of gut motility? Option A, excessive stimulation of the sympathetic nervous system by surgical stress. Option B, vagal nerve inhibition and the release of inhibitory neurotransmitters within the enteric nervous system, leading to decreased smooth muscle contractility. Option C, direct mechanical obstruction by surgical adhesions or intraluminal contents. Option D, a deficiency in specific digestive enzymes required for nutrient breakdown. Correct answer is B, vagal nerve inhibition and the release of inhibitory neurotransmitters within the enteric nervous system, leading to decreased smooth muscle contractility. Explanation. Scenario analysis. This scenario presents a professional challenge due to the potential for misinterpreting complex physiological processes in the context of patient care and regulatory compliance. The audit findings highlight a need for precise understanding of gastrointestinal physiology to ensure appropriate clinical decision-making and adherence to established medical standards, which are implicitly governed by the American Board of Colon and Rectal Surgery's purview. The challenge lies in distinguishing between normal physiological variations and pathological states that require intervention, all while operating within the expected standards of practice for board-certified colon and rectal surgeons. Correct approach analysis. The correct approach involves a thorough understanding of the specific physiological mechanisms governing intestinal motility and secretion, particularly in response to surgical intervention or disease. This includes recognizing how factors like vagal stimulation, hormonal influences, and the presence of specific nutrients or inflammatory mediators impact the enteric nervous system and smooth muscle function. Best professional practice dictates that a surgeon's interpretation of patient symptoms and diagnostic findings must be grounded in accurate physiological principles to guide treatment effectively and safely. This aligns with the implicit regulatory framework of the American Board of Colon and Rectal Surgery, which expects its diplomates to possess and apply comprehensive knowledge of the gastrointestinal tract's normal and abnormal function. Incorrect approach is analysis, an approach that attributes altered bowel function solely to a generalized slowdown without specifying the underlying physiological mechanisms, e.g., impaired neural signaling, reduced smooth muscle contractility, or altered hormonal feedback, fails to demonstrate the depth of understanding expected. This is a superficial interpretation that could lead to inappropriate management strategies, an approach that focuses on a single, isolated factor without considering its interplay with other physiological systems, e.g., attributing all postoperative ileus to a lack of specific dietary fiber, overlooks the complex, multifactorial nature of gastrointestinal function. This demonstrates a lack of comprehensive physiological knowledge, an approach that relies on anecdotal evidence or nonspecific patient complaints without correlating them to established physiological principles of digestion, absorption, or motility, is professionally unsound. This deviates from evidence-based practice and the rigorous scientific foundation expected of a board-certified surgeon. Professional reasoning. Professionals should approach such situations by first identifying the specific physiological system or process in question, e.g., motility, secretion, absorption. They should then recall or research the established physiological mechanisms governing that process, considering both normal function and common pathological derangements. The next step is to critically evaluate the patient's presentation and diagnostic data through the lens of these physiological principles, identifying any deviations from the norm. Finally, treatment decisions should be directly linked to the identified physiological abnormalities, ensuring that interventions are targeted and evidence-based, thereby upholding the standards of care expected by the American Board of Colon and Rectal Surgery. Question 18. Process analysis reveals a 55-year-old male with a 3-year history of irritable bowel syndrome, IBS, presenting with persistent abdominal pain, bloating, and altered bowel habits, despite trials of dietary modifications, low FODMAP diet, antispasmodics, and a short course of a selective serotonin reuptake inhibitor, SRI. He denies any alarm symptoms such as rectal bleeding, unintentional weight loss, or a family history of colorectal cancer. His initial colonoscopy 5 years ago was normal. He expresses frustration with his ongoing symptoms and requests further investigation to find the real problem. Which of the following represents the most appropriate next step in the management of this patient? Option A. Refer the patient for a trial of an investigational biologic agent that has shown promise in early-stage research for functional gastrointestinal disorders. Option B. Counsel the patient that his symptoms are likely psychosomatic and recommend a referral for psychiatric evaluation without further gastrointestinal workup. Option C. Schedule an urgent repeat colonoscopy with biopsies to rule out subtle inflammatory or neoplastic processes that may have been missed on the initial examination. Option D. Reassess the patient's adherence to previous treatments, explore potential triggers not addressed by the low FODMAP diet, and consider a trial of a different class of pharmacotherapy based on predominant symptoms, while reinforcing the diagnosis of IBS and managing expectations. The correct answer is D. Reassess the patient's adherence to previous treatments, explore potential triggers not addressed by the low FODMAP diet, and consider a trial of a different class of pharmacotherapy based on predominant symptoms, while reinforcing the diagnosis of IBS and managing expectations. Explanation. Scenario analysis. This scenario presents a common clinical challenge in managing irritable bowel syndrome, IBS, where a patient's symptoms are refractory to initial standard treatments. The professional challenge lies in balancing the need for further investigation to rule out organic pathology with the risk of iatrogenic harm, patient anxiety, and healthcare resource utilization associated with invasive procedures. The physician must navigate patient expectations, evidence-based guidelines, and the potential for misdiagnosis. Correct approach analysis. The correct approach emphasizes a systematic, stepwise escalation of diagnostic and therapeutic interventions, guided by established clinical practice guidelines for IBS. This involves a thorough reassessment of the patient's history, symptom profile, and adherence to previous treatments. If symptoms persist despite optimization of lifestyle and dietary modifications and pharmacological therapy, further investigation to exclude alarm features or alternative diagnosis is warranted. This approach aligns with the principles of prudent medical practice, prioritizing patient safety and cost-effectiveness, while ensuring appropriate care for potentially serious underlying conditions. It reflects a commitment to evidence-based medicine and patient-centered care, as expected within the American Board of Colon and Rectal Surgery's purview. Incorrect approaches analysis, pursuing immediate invasive investigations without a clear indication, or after a thorough review of treatment adherence and symptom-exacerbating factors, represents a failure to adhere to a stepwise diagnostic approach. This can lead to unnecessary patient discomfort, procedural risks, and increased healthcare costs, potentially violating principles of resource stewardship and patient well-being. It may also indicate a lack of thoroughness in reassessing the patient's condition, recommending a trial of a novel, unproven therapy without adequate evidence of efficacy or safety for IBS, or without considering established treatment algorithms, deviates from best practice. This could expose the patient to unknown risks and may not address the underlying issues effectively, potentially delaying appropriate management. Dismissing the patient's persistent symptoms as solely psychological without a comprehensive reevaluation and consideration of organic causes, especially if alarm features have not been adequately addressed, is a significant ethical and professional failing. This approach risks overlooking serious pathology and can erode patient trust. Professional reasoning. Professionals should employ a decision-making framework that begins with a comprehensive history and physical examination, followed by the application of evidence-based diagnostic and therapeutic algorithms. When initial treatments fail, a systematic reassessment is crucial. This involves identifying any missed diagnostic clues, evaluating treatment adherence, and considering the presence of alarm features that necessitate further investigation. The decision to escalate to more invasive diagnostic procedures or advanced therapies should be based on a clear risk-benefit analysis, patient preferences, and adherence to established clinical guidelines. This iterative process ensures that patient care is optimized, risks are minimized, and resources are used judiciously. Question 19. The efficiency study reveals that a modified laparoscopic sigmoid colectomy technique, while reducing operative time, has shown a statistically significant increase in post-operative fecal incontinence in a subset of patients. Considering the innervation of the colon and rectum, which of the following explanations most accurately reflects a potential cause for this observed increase in incontinence, requiring further investigation into the surgical technique's impact on neural function? Option A. Overdistension of the rectal vault during specimen extraction, causing transient neuropraxia of the pelvic splanchnic nerves. Option B. Inadequate ligation of the inferior mesenteric artery, resulting in compromised blood flow to the distal colon. Option C. Excessive retraction of the sigmoid colon, leading to ischemic injury of the bowel wall without direct neural damage. Option D. Unrecognized injury to the hypogastric nerves, which carry sympathetic fibers that contribute to rectal tone and sphincter function. The correct answer is D. Unrecognized injury to the hypogastric nerves, which carry sympathetic fibers that contribute to rectal tone and sphincter function. Explanation. This scenario presents a professional challenge in accurately assessing the impact of surgical technique on patient outcomes, specifically concerning the innervation of the colon and rectum. The challenge lies in correlating a specific surgical maneuver with potential functional deficits that stem from damage to critical neural pathways. Careful judgment is required to differentiate between expected post-operative changes and those directly attributable to surgical intervention, ensuring patient safety and informed consent. The correct approach represents best professional practice because it aligns with the American Board of Colon and Rectal Surgery's emphasis on evidence-based medicine and patient-centered care. Understanding the precise innervation of the colon and rectum, including the sympathetic and parasympathetic pathways, is fundamental to performing safe and effective surgery. Identifying the specific nerves at risk during a colectomy and correlating their potential injury with observed functional outcomes, e.g., bowel motility, continence, demonstrates a commitment to understanding the physiological consequences of surgical actions. This approach upholds ethical obligations by ensuring that surgical decisions are informed by a deep understanding of anatomy and physiology, thereby minimizing iatrogenic harm and maximizing the potential for optimal recovery. An incorrect approach that focuses solely on gross anatomical landmarks without considering the finer details of neural pathways would be professionally unacceptable. This would represent a failure to adhere to the highest standards of surgical knowledge and practice expected by the American Board of Colon and Rectal Surgery. Such an approach could lead to suboptimal surgical planning, increased risk of nerve injury, and ultimately, poorer patient outcomes, potentially violating the ethical principle of non-maleficence. Another incorrect approach that prioritizes speed of procedure over meticulous dissection of neural structures would also be a significant regulatory and ethical failure. While efficiency is valued, it must never compromise patient safety or the thoroughness of surgical technique. This would demonstrate a disregard for the intricate innervation of the pelvic floor and distal bowel, increasing the likelihood of unintended nerve damage and its associated functional sequelae. This directly contravenes the ethical imperative to provide the highest quality of care. A further incorrect approach that dismisses patient-reported functional changes as unrelated to the surgical procedure without thorough investigation would be professionally unsound. This failure to investigate potential iatrogenic causes of postoperative dysfunction is a breach of the physician's duty of care and could lead to misdiagnosis of nerve injury. It undermines the trust between patient and surgeon and fails to uphold the principle of beneficence. The professional reasoning process should involve a systematic evaluation of the surgical field, identifying critical neural structures based on established anatomical knowledge. During the procedure, meticulous dissection should be employed to preserve these structures. Postoperatively, any observed functional deficits should be carefully assessed in the context of the surgical approach, considering the specific nerves at risk. This involves correlating the patient's symptoms with the known functions of the injured nerves and the surgical maneuvers performed. This iterative process of intraoperative awareness and postoperative assessment ensures that surgical practice is both safe and effective, adhering to the rigorous standards of the American Board of Colon and Rectal Surgery. Question 20. The assessment process reveals a patient presenting with chronic abdominal pain, bloating, and altered bowel habits, with initial investigations for inflammatory bowel disease and malignancy yielding negative results. The physician is considering the next steps in managing this patient's complex presentation. Which of the following approaches best reflects current best practices for the diagnosis and management of suspected functional bowel disorder? Option A. Focus exclusively on prescribing a potent opioid analgesic to manage the patient's chronic abdominal pain, as this is a primary complaint. Option B. Advise the patient that their symptoms are likely stress-related and recommend general stress management techniques without a structured diagnostic evaluation for functional bowel disorders. Option C. Initiate a comprehensive diagnostic workup to definitively exclude all possible organic pathologies, followed by the application of Roman IV criteria for diagnosis and the development of a personalized, multimodal treatment plan addressing lifestyle, psychological, and pharmacological interventions. Option D. Proceed with a trial of empirical therapy targeting common functional bowel disorder symptoms without further diagnostic investigation, assuming the negative initial workup confirms a functional etiology. The correct answer is D. Proceed with a trial of empirical therapy targeting common functional bowel disorder symptoms without further diagnostic investigation, assuming the negative initial workup confirms a functional etiology. Explanation. Scenario analysis. This scenario presents a professional challenge due to the subjective nature of functional bowel disorders and the potential for misdiagnosis or inadequate treatment. The physician must navigate patient-reported symptoms, which can be influenced by various factors, while adhering to established diagnostic criteria and treatment guidelines. The challenge lies in differentiating between organic pathology and functional symptoms, ensuring patient safety, and providing effective, evidence-based care within the scope of practice. Correct approach analysis. The correct approach emphasizes a comprehensive, systematic evaluation that begins with ruling out organic causes through appropriate investigations. This aligns with best professional practice by prioritizing patient safety and ensuring that serious underlying conditions are not overlooked. The subsequent application of Roman IV criteria for diagnosing functional bowel disorders is a globally recognized standard, promoting consistency and evidence-based practice. Developing a personalized, multimodal treatment plan that addresses the patient's specific symptoms and concerns, incorporating lifestyle modifications, pharmacotherapy, and psychological support, reflects a holistic and patient-centered approach. This adheres to ethical principles of beneficence and non-maleficence, ensuring the patient receives the most appropriate and effective care. Incorrect approaches analysis. One incorrect approach involves immediately attributing all symptoms to a functional disorder without a thorough organic workup. This poses a significant regulatory and ethical failure by potentially delaying the diagnosis of serious organic conditions, violating the principle of non-maleficence. It also fails to meet the standard of care expected in the evaluation of gastrointestinal symptoms. Another incorrect approach is to solely rely on pharmacotherapy without addressing lifestyle factors or psychological components. This is professionally unacceptable, as it represents an incomplete and potentially ineffective treatment strategy for functional bowel disorders, which often have multifactorial etiologies. It fails to uphold the ethical obligation to provide comprehensive care and may lead to patient dissatisfaction and suboptimal outcomes. A third incorrect approach is to dismiss the patient's symptoms as psychosomatic without objective investigation or a structured diagnostic process. This is a critical ethical failure, demonstrating a lack of empathy and potentially leading to patient alienation and distrust. It also bypasses established diagnostic pathways for functional bowel disorders, violating professional standards. Professional reasoning. Professionals should approach such cases by first establishing a clear diagnostic framework. This involves a thorough history and physical examination, followed by judicious use of investigations to exclude organic pathology. Once organic causes are ruled out, applying validated diagnostic criteria like Roman IV is essential. Treatment planning should be collaborative, evidence-based, and multimodal, addressing the patient's unique symptom profile and psychosocial context. Continuous reassessment and adaptation of the treatment plan are crucial for managing chronic functional bowel disorders effectively.